Hello, this is Dr. Yanish, and this video is an endoscopic cubital tunnel release. This is one of 3 videos of endoscopic cubital tunnel release, and this particular patient is quite thin and has excellent anatomy through the scope. We'll start off the case by marking the anatomical landmarks. I will place 3 dots around the medial epicondyle and then make my incision immediately below that to a length of about 10 millimeters. The skin is incised with a 15-blade scalpel, being very careful, especially in this thin patient, to protect the ulnar nerve, which is not too far below the skin. Entering the cubital tunnel with Littler scissors, the ulnar nerve is visualized and protected. The ulnar nerve has just come into view, and now I'm demonstrating the ulnar nerve, which is nicely in view here, right between the 2 skin hooks. At this point, I'll advance an elevator through the proximal and then distal portions of the cubital tunnel. This is like a spatula that frees the ulnar nerve from the roof of the cubital tunnel. We're now ready to insert the clear cannula, which is used to perform the release. This cannula slides in easily with 2 fingers and should not meet any resistance at all. Once this is in place, the endoscopic camera is inserted into the wound. Make sure we get the light settings correct here. And above, on the top of the screen, this is the roof of the cubital tunnel. At this point, I can see that the ulnar nerve, which is below and to the right, is not centered. So I will pull the cannula back and use the portal at the distal portion of the cannula to help guide it back into a little bit better position. Now I have an excellent view of the roof of the cubital tunnel, and I'm visualizing that now as I pull the camera back. It does appear to look ligamentous. It is white and quite nice anatomy. Down and to the right is the ulnar nerve, which we'll take a better look at here in a minute. I'm going to spin the camera around so that the angle is pointing down. Now you'll notice in the center of the screen is the ulnar nerve. You can see gas patterns on both sides of the nerve. And it is a nice white structure right down through the center of the cannula, and it is below and protected behind the plastic clear cannula. At this point, we're ready for the endoscopic blade that is inserted onto the camera, clamped into place, and carefully inserted back into the clear plastic cannula. Once everything's positioned appropriately, the blade is advanced under the skin edge and carefully advanced forward, opening up the cubital tunnel proximally. The clear cannula is removed easily. The blade is removed from the camera, and we'll place the clear cannula back onto the trocar and advance it distally with the same technique as before, being extremely careful to not push through any resistance. This view is free of any nerve structure and does show a nice fascial edge. Looking down, the ulnar nerve is easily visualized and is in the center of the camera. Here you can see an excellent picture of the nerve centered between the muscle bellies here. This particular patient has almost no body fat, and this is quite a rare view of the ulnar nerve, and the reason that we chose this particular patient's anatomy to be shown as an easy dissection and easy visualization of the nerve. The nerve is visualized through the entire cannula from front to back as being free of the cutting edge, and now we'll prepare the camera again with the blade. That slides on and is again locked in place. Again, the blade is inserted into the clear cannula, and the roof of the cubital tunnel distally is opened. You'll see the muscle bellies collapse into the cannula as the fascia has been released. The plastic cannula is removed, and you can actually see through direct visualization that the nerve is free. I like to reinsert the camera back into the wound opening to visualize the ulnar nerve being free from the roof of the cubital tunnel. Really an amazing view of the nerve here, and an excellent picture of anatomy. Here's the nerve distally. There is a small amount of bleeding that is tolerated after the release. Any heavier bleeding would be dealt with cautery. The wound is irrigated with saline. I like to place a angiocatheter or IV catheter into the wound over the top of the nerve. This allows me to instill some local anesthetic at the end of the skin closure without advancing a needle and risking injecting the nerve. I perform a subcuticular closure with fluoromonocryl. This allows an excellent cosmetic result, and patients are extremely pleased with the appearance of this wound as early as the first post-op follow-up, which will be at 1 week's time. A thin layer of dermabond to seal the wound. And once this is dry, I will inject 0.25% Marcaine with epinephrine. The epinephrine helps with any postoperative bleeding when the tourniquet comes down. A sterile compression dressing is then placed over the elbow, followed by Coban. That's the end of this endoscopic cubital tunnel release. Thank you for watching.